Hello, everyone. Thank you for joining us for improving rural health recruitment and retention through telementoring, leveraging lessons learned from the pandemic. I am Chris Salyers, the Director of Programs and Evaluation with the National Organization of State Offices of Rural Health, or NOSORH. Today, we're going to do a couple things. We're going to talk about the existing challenges for the rural health workforce and how the COVID pandemic has sort of changed those a little bit or brought some new ones to light. We're going to talk about some successful examples of informal telementoring that took place throughout the pandemic and what we can learn from those experiences and activities as we go forward through past the pandemic. Before I get started, a little bit about who we are. NOSORH is the membership association of the 50 state offices of rural health. There is a state office in every state, and if you have not had the opportunity to be introduced to yours, we would love to do that. So please feel free to reach out to us or look on our website for that contact information. NOSORH exists to help build the capacity of those state offices and their rural health stakeholders. We do that through leadership development, advocacy, education, and partnerships, ultimately to improve the health of rural Americans. Before I go any further into the presentation, I also want to say thank you to our members. The information that we're going to share today about these successful models, some of them were done by state offices of rural health and shared with us. Others were really cool things that were going on in their state, and they just wanted to make sure that we knew that they were going on so we could share them with others. So first, let's talk a little bit about the existing challenges for the rural health workforce. These existed before the pandemic, and some of these may be well known to some of you, but I want to make sure that we talk about them very quickly. So recruitment and retention of health professionals has been a long-standing challenge, something that we have federal and state policy to address. So for instance, we have the health professional shortage areas, or HPSAs, which were created in the 80s as a way to identify communities that had the highest need, to then be able to funnel resources, federal resources and then state resources to these communities of high need. Things like high incentive programs were key to that, like loan repayment or tax incentives of some type. So these have been a long-standing issue. And a few years ago, the Shortage Designation Management Project did a little bit of tweaking on the back end of what HPSAs are, and it made some organizations drop their score a little bit lower than where they were before. And so for some organizations who really relied on those incentive programs as a key component of the recruitment and retention efforts, that's something they're going to have to rethink. But meanwhile, we saw some organizations who were not eligible or not competitive, I should say, for HPSAs and those incentive programs that are now going to be higher up on that score. So this is a long-standing issue, and it's not something that was going to go away pre-pandemic, and it's not going to go away post-pandemic. But recruitment and retention it remains one of the largest challenges to the rural health workforce. I also want to note the lack of specialty expertise. We look at the rural health landscape, and the infrastructure is really being a lot more about primary care. That's where most of the access comes from. So we put a lot on these rural primary care physicians and advanced practice providers to know everything and be everything. And that's definitely not the case. It's not fair to look at it that way. And rural providers don't have that specialist just down the hall that they can then go and say, hey, let's do a case consult. Tell me, what is my best course of action? Do I need to refer them to you? Is this something we can do in a primary care setting? What's that look like? And so that's a challenge when you have to be everything and all of it, but you don't have anybody to turn to for help and support. And then the third thing I want to talk about here is rural hospital closures. You've probably seen a lot of that in the news, along with reduction in service lines. Hospitals and clinics are having to close certain components just to make sure that they can keep the doors open. This is most prominent in rural obstetrics. And the University of Minnesota has been doing some great research in this area in order to figure out what some of the root causes are and see what we can do Meanwhile, pre-pandemic, the Federal Office of Rural Health Policy was putting out a rural maternity and obstetrics program, a pilot program to see where they can make the biggest impact moving forward. So this too was a big issue prior to the pandemic and will remain one going forward. So what has been COVID's impact on all of this? Recognizing that we are still in the pandemic, we are still very far from being done with this. And there's going to be some time needed on the back end to really analyze that data and make some determinations. But anecdotally, from the state offices of rural health and from other key stakeholders, as well as news articles and whatnot, we can start to really piece together what this impact is starting to look like on the rural health workforce. Key to that is staffing shortages. I mean, we already had that in rural communities, was already an issue, but we are really exacerbating those as a result of the pandemic. So we had these people who had to be laid off. We had to close the doors. We had to shut things down, and they got laid off. And those people may have gone in search of another job, or they may not be willing or interested in coming back to the workforce at this time. So the applicant pool is not as robust as it was pre-pandemic. But what about all those people who weren't let go, that they were essential employees throughout the entire pandemic, right? What we're seeing with them is an increase in retirements, an increase in burnout, and people just leaving the profession entirely. And some of that was to be expected. There was a lot of literature out there that we knew that there was going to be a shortage in primary care physicians by about 2030 as a result of retirements. But that wave is probably going to be coming a whole lot sooner now as a result of COVID. So we'll have to wait and see what some of this research shows us on the back end. But based off of what we see anecdotally, this wave has been pushed sooner than we initially anticipated. Higher wages are more competitive in other markets than rural. And this is really having an impact. And when I say competitive markets, I'm talking about urban markets who have the funding and the resources to be able to pay a higher wage. We're seeing this particularly within traveling nurses right now. I saw one report of traveling nurses making up to $52 an hour, whereas if they stay in their local community at a critical access hospital, they may only be making about $25 an hour. So these people are opting to take these jobs, especially if they have that flexibility in a traveling role, to then be able to make more money. And lastly, vaccine mandates. And while not every hospital or healthcare organization has these in place at this point, we're not seeing a huge impact percentage-wise and numbers-wise on the people that are leaving the workforce as a result of the vaccine mandate. I haven't seen any reports yet of any more than 3% of any facility staff being lost because of the vaccine mandates. But when you start with an already short-staffed facility, any loss of a workforce is going to be really felt. So even though it's just 3%, that's 3% that we really need in that rural health workforce. And we'll see how that plays out going forward. So let's talk a little bit about some successful telementoring activities that took place during the pandemic. Most of you are really familiar with the Project ECHO model and what that does. And we saw a lot of states, particularly in their primary care ECHOs, they were looking at ways to incorporate infectious disease specialists. So when I bring this up, because it goes back to one of those key challenges we first talked about, and the lack of specialties within rural areas. Using this Project ECHO, they were able to connect rural primary care providers with a type of specialist that was not very prominent in rural. So by bringing in the infectious disease specialist, they're able to support rural providers in a way that they couldn't otherwise. In line with that, we saw ECHOs being used to support the rural health workforce in ways that focus more on relationships. A great example of that was the Nevada Office of Rural Health developing an ECHO to connect their rural hospitals and clinics with the state lab. For many of them, there was no relationship there pre-pandemic. But when all of the specimens had to be turned over to the state lab and there were some challenges with that workflow, being able to connect people through that ECHO and form those relationships was extremely beneficial in making sure that people's specimens were reviewed and results got back in a timely manner. And then all across the country at the same time, there were these informal listening sessions that were going on. They were facilitated conversations by Zoom and by telephone. And many of them were hosted by the state offices of rural health or other statewide organizations focusing in on rural health. And what they did is they provided a network, a peer-driven opportunity for people to get on a call and say, hey, I'm having this challenge. Are you guys having this challenge? What's worked for you? And in some instances, we even saw that turn into sharing of staff, sharing of resources. I mean, it was phenomenal to see how people were able to take those just simple phone calls and really run with it and make something impactful during the pandemic. So how do we take what went on, what we saw go on during the pandemic, and make that impactful going forward? How can we learn from those lessons, right? And we saw that there was a lot of success, whether it was informal or formally, right, with the state level telementoring, and they were using effective models. We already knew that Project ESCO was effective in what it did. So we just built upon it, right? And that's something important to think about going forward. And what the Rural Telementoring Training Center model brings to the table. By using that model, we're combining a variety of different ways in which people can connect and be mentored or mentor, right? And we're using all of that at the same time to create this really impactful experience for our rural health professionals. But at the same time, if you work in rural health, you also recognize that there is a high need for flexibility because we put a lot on our rural health workforce, don't we? So I think of the rural primary care physician who's seeing patients for 12 hours a day, right? In clinic, 12 hours a day. And then at the end of that shift, she still has to go back and do 2 hours of charting and documentation. Do you think that at the end of that 14-hour day that she really wants to sit down on a Zoom and say, hey, I had this problem today. Can somebody talk to me about it? We have to be flexible and know that we're putting people into positions where they might be overworked. So let's reduce some of that burden. Let's give them models and opportunities to connect in ways other than just a Zoom platform or a lecture. And that's what the RTTC model brings, right? If she prefers to just shoot off an email early in the morning to some of her network and say, hey, I'm experiencing this challenge. What ideas do you have for me? At the end of the day, when she has the time to sit down to really think and look at that, then she can digest what that says and make use of it. But that's just one piece of it, right? We need to be combining all these pieces together into that impactful experience. And that is what the RTTC model brings for telementoring going into the future. And so we've talked about some of these really awesome examples of what's happened. And we want to invite you to share more of those really great examples of what has been going on across the country during the last year. So on the third Thursday of November, this year, November 18th, we host National Rural Health Day. It is an opportunity for us to celebrate what's going on in rural communities and get away from a lot of the narrative that we see around disparities and talk about those positive things. We'd invite you to share your examples of what you've done with telementoring and those successes on your social media accounts, not just for us, but for everyone to see how great you guys have done. Use the hashtag #PowerOfRural. And for more information on that, visit powerofrural.org for toolkits and resources. It's all free, but we would love to see you celebrate with us on National Rural Health Day to really highlight those great things that are going on. So with that, I'm going to close here, and here's my contact information. If you have any questions or comments about any of the information that we've gone over today, please feel free to reach out to me. And there's the links to our websites. We look forward to you joining us for National Rural Health Day, and make sure to use that hashtag #PowerOfRural, not just on National Rural Health Day, but all the time. Thank you.